All right, welcome back, everyone. Hi again, Kate Myers from the California Healthcare Foundation. And hopefully everyone is back at their computers and ready to dive in for the last half of our last day for our statewide convening. So what we wanted to do to start out, just to get everyone kind of re-energized and re-engaged, is to do a little interactive activity. So we have something set up called a Mentimeter. There's a link in the chat that you should see from Kita, from the Coalition for Compassionate Care. It says click link to participate in word cloud activity. So if each of you will click on that link, it will take you to a website that allows you to do an activity to put in a response to the question, what is one word that represents what you are hoping for with your palliative care program post-COVID? So again, if you're just getting back on audio and hearing me, we are currently clicking on the link that's in chat, the menti.com link. Click on that and on your own computer, access that page and answer the question, what is one word that represents what you're hoping for with your palliative care program post-COVID? And as you'll see, the word cloud will start to grow as more of you put in your answer to that question. So you can see on the screen how that's changing or staying the same with some common themes as people type in their responses. So I'll reiterate those directions again in a moment if there's anyone else who's joined just a minute or two late. And after a few minutes, once we see the word cloud start to slow down, we'll see what we've got. We'll see what the themes are. So again, if you're just joining back and wondering what's going on, we are doing a little interactive exercise to get us started for the last session. And to participate, just open up the chat and you'll see towards the very bottom of the chat, a note from Kita that says click link to participate in word cloud activity. Click on that link. It'll take you to a website called menti.com with a question that we want you to answer with one word. What is one word that represents what you're hoping for with your palliative care program post-COVID? And I see someone having system problems, so maybe I'll put their word in for them. Their word was growth. Another that just got sent to me is care. So we'll populate those live in just a second. And let's see where we are. Oh, and there's an explanation here. I guess there was JEDI work, which is apparently an acronym for Justice, Equity, Diversity, and Inclusion. I think we've all heard of DEI. I don't know that we've all heard of JEDI. Great. All right, a few people are having trouble accessing it. It's possible that there may be blocks from some systems for certain websites, as there often are. But let's see, we've got pretty good level of response here. So we can see what some of the themes are. I think you're all probably familiar with word clouds, but when there's a bigger word, it means that probably more than one person input that word. So we see some themes around growth, expansion, innovation, restoration, direction, enhancing telehealth, and some other smaller words, but in there for sustainable, orderliness, partnership, JEDI work, which we heard is justice, equity, diversity, and inclusion, safety, dignity, stability, sustaining, more in real life. Yes, I think we're all looking forward to more in real life interactions and work. Sustainability, in-person IDT, again, this in-person interaction with team members, optimization, engagement, solid, I like that word. What are you hoping for post-COVID? Solid. And improvement. Well, that's great. I'm really excited to see where people are looking to the future, and it feels very optimistic, I have to say, this these hopes are optimistic and I think realistic. So with that, thank you for participating in our interactive activity. And as I mentioned at the beginning of the day today, we're going to be spending time in our last portion of the meeting talking about some of the variation we've observed in experiences and approaches to implementing palliative care. So Kathleen Kerr from Kerr Healthcare Analytics, who I think you are probably all familiar with, is a longtime consultant to CHCF on a variety of palliative care related projects, as well as broader consultation with organizations around the country. And we're really happy to have Kathleen here today to talk about experiences implementing palliative care, and to spend some time in some breakout sessions in a little while talking about people's goals and hopes for the future for their programs. Kathleen.
Hey, thanks, Kate. And hi, everyone. The word cloud was very interesting. I think more predictable and kind of like the before times is what I'm hoping for. Yeah, as Kate mentioned in this last session, we're going to talk about experiences implementing palliative care. And we got at this a little bit in some of the survey data yesterday, but here's a chance to look at some different information, a little more qualitative information to sort of expand on some of those topics. The objectives for this session are to learn about variation in approaches that plans and providers have used to implement Medi-Cal palliative care, and also to consider plan and provider experiences offering palliative care that meets or exceeds the Medi-Cal requirements, and how those experiences align with or differ from your own experiences. And then finally, to learn about and share some promising practices that may optimize implementation. So the basis for this session, if you cast your mind back to 2017, before SB 1004 was implemented, there were no standards around really to help guide what a palliative care program would look like. And in response to this, actually starting back, I think I want to say back in 2015, the Coalition for Compassionate Care of California, in partnership with Blue Shield of California, assembled a group of plans and providers to come up with some consensus standards for community-based palliative care that could be agreed upon and released to try to offer some guidance to help people know what does good care look like and to reduce variation. As that process was going on, the Allplan Letter that guides what plans are required to offer to members was being released by the Department of Healthcare Services. And it turns out that the standards, the CAIC, the California Advanced Alternative Standards, and the requirements in SB 1004 are quite similar. And so we have these sort of two sets of requirements that became available roughly at the same time. In response to that, the California Healthcare Foundation sponsored a pilot, an evaluation of what it's like to deliver palliative care that meets or exceeds some minimum standards, which is the intent of both the CIC standards and the SB 1004 APL requirements, so that they set a minimum, the minimum of what folks have to do. So through this project, there are 4 payers and 10 provider organizations that have been delivering palliative care in Sacramento and/or Los Angeles. And it does cover multiple business lines. So in addition to managed Medi-Cal, there's also Medicare Advantage and commercial populations that are included. All of the plans and providers are engaged in contracts. Some providers have contracts with multiple plans, some with just one, but all of those contracts require for delivering services that meet or exceed the minimum standards spelled out in the CIAC document, and then also in the SB 1004 Allplan Letter. One of the big purpose of the pilot is to answer a few important questions. Does having minimum standards make it easier to deliver quality, sustainable palliative care? And are the financial outcomes that are generated when you have these minimum standards, are those sufficient to make it a good proposition for both the payers and the providers? And then finally, we're also gathering information that tells us, do patients and families value the services that they received? As part of that evaluation project, we've gathered some information from the participants, which I think are really pertinent to the topics that we're discussing in our convening yesterday and today. So we're going to be looking at the variation that exists in how plans and providers have operationalized their Medi-Cal palliative care programs. And also we have some opinions about how things are going. So through the CIC pilot project, we've gotten information through oral and written surveys and interviews, group meetings, etc., where we've gathered information both about the structures and processes and variation, as well as experiences with 5 key elements of implementing contracts for delivering palliative care: eligibility, services, staffing and care model, payment model, and measurement and reporting. So what we're going to do for the next few minutes now is look at some of that information about variation and experiences with those 5 key areas, and wherever possible, wherever it's pertinent, compare that to the minimum standards that are spelled out in the SB 1004 APL. We'll then move into a small group discussion to talk about your own experiences and your reactions to the information that was shared, and then we'll come back together in a large group to hear about what went on in the small groups. So let's start with eligibility, a super key element of implementing a palliative care program. Now, the SB 1004 requirements, of course, there's 3 parts to the eligibility criteria. There's general criteria. So is the member using the hospital or the emergency department to manage their illness? Would death within a year be expected, given the state of their illness? Are they willing to participate in advanced care planning, and so on? There's a list of these general criteria. You also have to have a qualifying diagnosis, and at minimum, that is cancer, COPD, CHF, and liver disease. And then also there needs to be evidence of advanced disease. And that's typically, that's disease specific, and it's typically a combination of utilization history, either hospitalizations or having had a certain number of chemo rounds, and then also biomarkers. So for example, an ejection or a MELD score for liver disease. And we know, all of us on this call know, that at minimum, the Medi-Cal managed care plans must ensure access to palliative care to individuals with advanced cancer, COPD, heart failure, and liver disease who meet both the general and the disease-specific criteria. So what is the operational variation that we see? So that was the minimum. How have folks modified that as they've implemented programs? Well, there's really 2 big areas. One is specific inclusion of additional eligible diagnoses, stroke, end-stage liver disease, severe dementia, a few others, as well as relaxing some of the criteria that are based on the biomarkers and the evidence of advanced disease. And as you hear about variation as we go through these 5 areas, you might ask yourself, well, what impact would that have, say, on the number of referrals? Would it create confusion on the part of people who might refer patients if one plan is using one set of criteria, another plan is using another? Would changing the eligibility criteria change the types of supports that these patients need? Does somebody with a different disease than the 4 original ones need a different type of care? And would it have an impact on outcomes, both clinical and satisfaction and utilization and fiscal? So there's consequences in lots of different directions to moving above the minimums. And as we think about variation, it's worth thinking about what those consequences would be. In terms of the experiences that the plans have had with their perceptions of the eligibility criteria as written in the SB 1004 requirements, we asked them a few questions about this to prompt the sharing of information. I've included those for you. And really what we heard from the plans was that, that as written, the eligibility criteria are missing some important diagnoses. And also, sort of paradoxically, that they may be too inclusive. So there's some issues with inappropriate referrals for those who have any of those 4 listed chronic illnesses that perhaps just needed extra pain management. Some enrollees are more advanced illness versus palliative care. So if you ask the surprise question, would you be surprised if this person died in the next year? The answer could be yes. Yeah, I would be surprised. And the eligibility criteria as written didn't quite tease that out. And it was, I think, I thought that perhaps it would be helpful to include a palliative performance score in the criteria to help to hone in a little bit better on folks with sufficiently advanced disease for qualifying for team-based, home-based palliative care. In terms of the provider experiences, they had kind of a different minority of the providers felt that the criteria were effective and inclusive, that they were about right, but most of the providers thought that they were missing patients and that the criteria were too restrictive. A terrific quote from one of the providers: "Sometimes we have bedbound patients that would benefit from our services that somehow don't meet criteria." There's a feeling that the eligibility criteria should be broader in terms of the number of diagnoses that are covered. And there's just a general feeling that there's a lot of patients who would benefit who still aren't getting services. So different takes across plans and providers. Services. So we're all familiar now with the 7 minimum required services for care, advanced care planning. You have to conduct a comprehensive palliative care assessment and consultation. You have to develop a palliative plan of care. You have to deliver care by using an interdisciplinary team. Someone on that team needs to take responsibility for care coordination. You need to be able to offer pain and symptom management, and you need to attend to referring or providing mental health and medical social services. There are also those 2 optional elements. 24/7 telephonic support is mentioned in the APL as something that plans are encouraged to require their providers to deliver, but it's not required by the state. And chaplain services, spiritual support, was something that existed in the early versions of the APL, but that was eventually dropped. So that's an optional requirement. In terms of variation, not surprising, those 2 things that are sort of highlighted as the points of variation in how SB 1004 palliative care has been operationalized. Some plans require delivery of spiritual care, others do not. Some require 24/7 availability, and others do not. In terms of the plan experiences with the required services, in general, they were pleased. The idea is that they were matching well with what members need, and that they promote delivery of a holistic approach to care. Spiritual support was seen as an important add, as was the 24/7 phone line to create expanded access to members who might need care. And the only thought about what might be missing is that members and families certainly could use more caregiver services, so support for the people who are taking care of the members. The provider experiences were a little different and a little mixed. Some gaps were identified in terms of services. The services that were provided felt great, but there was a feeling that what was missing was consistent access to mental health providers and substance use facilities and specialists. And while that's not necessarily a typical inclusion in a palliative care service, the point was that their members needed that care, trying to deliver a lot of it themselves. Also, bereavement support was identified as being something that was missing. And one provider cautioned actually about offering too rich a benefit, about adding too many things to the required services. Sometimes offering too much under palliative care, like home health aid services, may discourage patients from electing hospice care. So that would count as an unintended consequence of increasing the required scope of service. In terms of staffing and care model, the guidance from the state is actually pretty general. The Department of Healthcare Service recommends using providers with current palliative care training and/or certification, but they don't require it, and they don't specify what that training or certification would be. And there's also a lot of flexibility in the types of organizations that could be engaged in to deliver this care. So basically any type of healthcare or community-based organization that has licensed clinical staff and/or training in palliative care. So how has that been operationalized? What does the variation look like? Well, some plans require their Medi-Cal palliative care providers to be certified by CHAP or by the Joint Commission. Others do not. Also, some get very specific about visit frequency and which disciplines need to be on the team and how much they need to be engaged with patients. So, for example, requirements might be as specific as there need to be 2 RN visits per month, or the palliative care team prescribing clinician needs to see the patient at least once every 3 months, and when goals of care change. So a lot of variation in how specific the staff, the care model needs is in the number of contacts, the frequency of contacts, and the types of contacts. In terms of the plan experiences with the care model, benefit from further training about palliative care, differentiating it from hospice, and also best practices for communicating with primary care providers and other clinicians and sharing information. In general, it was felt also that the payment model and all of these plans that participated in the CIC project are using a per enrolled member per month payment. The feeling was that the payment model supports the care model. So by paying a case rate, we give our vendors flexibility on which services are provided. For example, the vendor may substitute an extra social work visit for a nursing visit if medically appropriate. In terms of the organizations, were mostly satisfied. The staffing works for us. Our staffing and care model often exceed the contractual requirements. Plans tend to be very flexible in authorizing additional visits when requested. However, some other issues were also identified. Some providers felt that they were being asked to offer more visits and contacts than patients or families want. And in particular, this occurred if there was very specific requirements within the contract about number of visits by a specific type of discipline within a certain time period. There was also concerns raised that meetings and trainings and other non-clinical work actually deliver patient care. And also there was concern that contacts can dictate the type of support that a patient and family are getting versus being guided by the needs of the patient. So a little bit of chafing against being held up against very specific requirements in instances where that didn't align with their perceptions of what a patient or family might need. Measurement and reporting. Now, the Allplan Letter, the guidance that's given to the plans about what they need to require of their members, it doesn't say anything about measurement and reporting. And here's some information that Anne presented yesterday that told us that there's actually quite a bit of variation in that different plans are receiving from their Medi-Cal palliative care vendors. So that actually is very much replicated in the information that we gathered from the CIC participants. There's tremendous variation in the amount of data that's reported to the plan, and it went anywhere from no information was shared beyond claims data that's submitted by providers that sort of documents the number of encounters, all the way on the other end of the spectrum to weekly reporting that summarizes encounters and resulting care plans. There's also differences in audits of services and processes. We have some plans doing routine audits of quality. All right, so plan experiences with measurement. In some ways, it was acceptable, and they felt that the measures of the information that they were asking the palliative care vendors to supply was appropriate. And some deficits were also identified. So some plans weren't getting any member satisfaction data, and they found that to be something that they very much thought that the requirements that were being placed on the providers were too burdensome. And another also felt that the data that was being supplied was just not adequate. It wasn't giving a good picture of the actual quality of care that was being delivered. In terms of the providers, a minority felt that the requirements that were being placed on them for reporting were acceptable, felt that for the most part, the data collection was reasonable and necessary. There was also quite a few providers that felt that there were some deficits. So for example, FINE will give you the data, but special reports have to be created, and that takes effort. So that needs to be accounted for to cover the cost of that time and effort. Some felt that the administrative requirements were too burdensome, and also noted that since the tended to vary plan to plan, contract to contract, it made it quite difficult to comply with requests. Another provider noted that it really didn't feel like the type of information that they were being asked to deliver was getting down to the level of what was actually quality of care. And also, it was noted that all the effort that it takes to report on the number of visits and the number of calls and participating in IDT meetings and so on is very time consuming and likely unsustainable as the provider's census grew. Another area that's central to implementing a palliative care program. As we saw yesterday, there's a wide range of payment mechanisms that are used to create these contracts between palliative care vendors and palliative care providers. The Allplan Letter, the SB 1004 guidance, doesn't say anything about this. And so we know that, and we know from the information that we saw yesterday, that as a whole, across all plans and all providers that at least responded to our survey, we saw quite a bit of variation, everything from fee-for-service only to per-enrolled member per-month payments, and then incentive payments and so on. It should be noted that all of the plans that the IC project offer a per-enrolled member per-month case rate payment, but there was still variation, specifically in whether or not there were formal tiers of service with different payment amounts for different types of patients getting care in different types of settings, often based on acuity, and then also whether or not supplemental payments, in addition to the per-enrolled member per-month payment, was allowed for those that had high utilization. In terms of the plan experiences with the payment model, the case rate was universally endorsed. Monthly case rates work. The monthly case rate enables provider flexibility with care delivery. However, there was still some hesitancy about whether or not there was alignment between the cost of the program and the impact in terms of one plan in particular felt that they didn't quite have enough data to assess fiscal impact for their palliative care program. Once the service expands, we will be able to measure this, but at this point, it is not recognized for cost avoidance. In terms of the provider experiences, of course, they said they preferred a case rate, but there were also some concerns about sustainability, in particular that whether or not that case rate was adequate. Another provider noted that the case rate varies, and in some instances, it is difficult to provide excellent palliative care with a lower rate. So the amount of service and the types of outcomes you can achieve will depend upon how much compensation you're receiving. And most contracts, another provider noted, require care delivery that exceeds reimbursement. So there's definitely a disconnect there between plan and provider experiences, and perhaps an opportunity to explore ways to make care delivery costs go down by becoming more efficient, or to re-examine the amount that's being paid to create better alignment. All right, so that's the end of the presentation of the information that we gathered from the CIC teams. And what we want to do now is to break up into small groups and have a chance to talk about how these 5 issues, eligibility, services, staffing care model, payment model, measurement and reporting, have played out in your own experiences of implementing palliative care programs. And for provider organizations, of course, the way that you're delivering care, as you think about these 5 areas, is often driven by your contracts. So very often you would have to consider modifications to these areas only of engaging with plan partners. So we're going to structure this by having the groups, everybody in the group, answer 2 questions. Which implementation area would you like to modify for your own organization, and why? And 2, what promising or successful practices have you used or heard about in any of these areas that you wish were used more widely? So what's going to happen now is we're going to be randomly split up into small groups. We'll address those 2 questions. Every group will have a facilitator. Hello, facilitators. Thank you for being here. And then we can have a general discussion if time allows. And then we're all going to come back together after 30 minutes to share some of the highlights, rapidly share some of the highlights of those small group discussions.